The time is 100 minutes, including the question and answer session.
Okay.
Okay, can you hear me?
It is a bit not clear. I don't know. Yeah.
Wifi-nya kenapa?
Okay. So we have about 2 hours, right? 2 hours, including question and answer.
No, I've been asked Miss Uni about the time, and she tell me that the time is 100 minutes, including the question and answer session. Do you get it?
Oh, okay, okay, right.
Yeah.
Okay, good. Yeah.
100 minutes. So it's yeah, it's maybe 100. No, 1 hour and 40 minutes, I guess.
Yeah. Okay, it's fine.
Ya, right.
Right.
Ya, teman-teman nanti bisa lihat di meeting chat untuk absensinya di akhir sesi. Nanti jika ingin bertanya kepada Dr. Siti, silakan ditanyakan langsung atau nanti bisa ditanyakan di meeting chat melalui bahasa Indonesia. Nanti akan saya bantu untuk bahasa Inggrisnya. Baik. Okay, Dr. Siti, are you ready for deliver your presentation?
Yes, I'm fine. Thank you. Yep.
All right. So, okay, time is yours.
All right. Thank you so much, Aisha. Good morning, everyone. How are you doing?
Good morning.
Hope that everyone, good morning, everyone. So hope that you are doing well in this difficult period. Yeah.
Morning.
So I don't know. Yeah, I don't know if you are also in movement control order over there, MCO period as well, right?
Yes, ma'am.
Yes. Okay. So remember we have been together for these 3 lectures. Now today is our 3rd lecture. In the previous 2 lectures, we've been discussing about the cultural, about the trends, about the issues in the area of maternity. And then the 2nd lecture, we talk about the pregnancy, and we talk about the what we call pregnancy and placenta development and fetal development. So today is a time for us to learn about the labor process or the childbirth process, and what are the roles of nurse in taking care of the mothers during the labor. Yeah. Right. So here today we are going to see what we call 4 topics, 4 small topics inside this lecture, which is the first one. We're going to see the physiology of normal labor, and after that we want to know what are the factors that cause the childbirth or cause the labor. And after that we're going to move to the stages of labor. There will be 3 stages of labor that we will discuss later, and the last one we are going to see what are the nursing roles or responsibilities, or how do we manage patient during childbirth process or during labor. Right. So what is labor? Labor is the process by which the products of conception are expelled out from the woman's body. So what are those products of conception? The products of conception may include baby, of course, and then placenta, the umbilical cord, as well as the amniotic fluid inside the uterus cavity. So there is 4 products of the conception: baby, placenta, umbilical cord, as well as the amniotic fluid, right? So only after this all product conception expelled out from the woman's body, then only the labor will be end. Okay. So let's do the first. Sorry. So let's do the first one. We are going to see the physiology of normal labor. So how does actually the labor occur? Okay, how does the labor occur? So the labor process begins with the uterine contractions. That means if there is no uterine contractions, the normal labor might not occur. So how does uterine contraction occur? It started with the lower segment of the uterus. Okay, here is the lower segment of the uterus. Okay, so the lower segment of the uterus becomes more stretched, okay, and become more thin. And then after that, the cervix dilates. So this one, if you compare the first figure with the second figure, now the what we call the lower segment now become more thinner. Okay, become more thinner. At the same time, the cervix also dilated. Okay, here we call it cervix. So here you can see a small opening, but compared to the second picture, here the cervix now is dilated, which means that it become more bigger in terms of the opening. And after that, the birth canal is formed, meaning the passage towards the baby birth is formed now. So now you have here the cervix and here is the vagina. And then the baby will be delivered through this birth canal. At the same time, the baby descends through the pelvis. So when the baby descends with the uterine contraction, then the normal labor will occur. Right? So the other things that happen during the uterine contraction is that the activity of the myometrium. Remember in the last lecture, I have spoken about the layers in the uterus. There are 3 layers of the uterus: the endometrium, the most inside one, and the second one, or the intermediate, or in between the inner and the outer layer, is the myometrium. So myometrium, of course, they have muscles. And the function of the myometrium during labor is that they're going to contract and relax. Okay, they're going to contract and then relax. So the contraction and relaxation of the myometrium will cause the uterine contraction. However, the contraction and relaxation, the relaxation of the myometrium during labor, it not occurs 100%, which means that the muscles might be contract and then relax. In a general condition, the muscle relax means they are fully relaxed. But in case of this myometrium, it is not relaxed in what we call the muscle fiber do not return to the former length. Okay, but it becomes little bit shorter. So this one we call it retraction, can be contracted and retracted. Or in other words, we can call a contraction and retraction of the myometrium that will cause the labor. So when the contraction increase, more contraction, and the woman will feel more pain, of course, then it become more frequent, it become more stronger, and the duration become more longer, then the labor will progress well. There are 2 terms that we want to understand here. The first one I mentioned just now about the efface, which means that it becomes more thinner, the cervix becomes more thinner. And the other words that we like to know is dilation, dilation of the cervix or dilation of the os, which means that the os becomes more wider or becomes more, the opening becomes more bigger or wider. Okay, if you can see here, this one we call it external os, and this one is the internal os. So you can see here now both of these internal and external os is going to open here. So this is the labor progress. So this one is before the labor, and this one during labor, and this one the baby now ready to be expelled out from the woman's uterus. There are also other causes of the labor. Right? The first causes of labor is the progesterone withdrawal, the reduction of the hormones, okay, which is estrogen and progesterone. But normally the progesterone withdrawal will cause the labor. After this, I'm going to explain it in details. The second one is the high level of the prostaglandin. So the women need prostaglandin in order for them to have labor. So without this prostaglandin, the woman might not have the normal labor. The other hormones that is important during labor is corticotrophin releasing hormone. Corticotrophin releasing hormone. So how does these hormones react? Okay, let's see this figure. So the causes of labor can come from the maternal factor and also from the fetal factor. So this one is the factors that come from the baby and this one from the mother. For the mother, the vagina of the mother becomes more stimulated and stretched. The cervix also like that, it becomes stimulated, it is stimulated and stretched, as well as the uterus. Okay, the uterus is stimulated and stretched. These three mechanisms or these three changes will result in the neurohyphosis that release oxytocin. Okay, so the oxytocin will cause the uterine contraction. At the same time, the cervical stimulation will cause the increase of the prostaglandin. Okay, and then the prostaglandin, as I mentioned before, is important to cause the contraction. At the same time, the uterine stimulation and stretch will also increase the oxytocin receptor sites, because now we have the oxytocin that is excreted by the neurohyphosis at the hypothalamus, right? So oxytocin is released. Therefore, we need the receptor for the oxytocin to bind with. Therefore, the oxytocin receptor will be increased by the uterine stimulation and stretch. Okay, right. So at the same time, just now I mentioned about the factor from the baby. So at the hypothalamus of the baby, at the baby's brain, there is corticotrophin releasing hormones increase, and this hormone will go to the pituitary gland and ask the pituitary gland to release the corticotropin hormone. And then the corticotropin will go to the adrenal gland of the baby, then ask the adrenal gland to release cortisol. And then the cortisol will release the oxytocin, will cause the oxytocin release more. And this oxytocin will go through the umbilical cord, through the placenta to the umbilical cord, and then will cause the uterine contraction in the maternal side. At the same time, the oxytocin release will go to the placenta, go to the umbilical cord, and at the same time, they will cause the withdrawal of the progesterone. And this withdrawal of the progesterone will also at the same time increase the receptor, the oxytocin receptor sites, yeah, and then will cause the uterine contraction. Okay, that's the process. I hope that you can follow. If you have anything to ask, you might want to interrupt, or you can ask in the end, yeah. Right. So now we are talking about the signs and symptoms of labor. So the labor, sometimes the woman might not sure whether the signs that they are experiencing right now is the true signs of labor or it is not the true signs of labor. So we have divided into two. We call it true signs of labor and false signs of labor, or true labor, false labor. So how do you know if the labor is now is going to begin? Okay, so the first signs is the contractions becomes more regular. What does it mean? It means that if the woman has the contraction every 30 minutes, every 30 minutes the woman will feel painful contraction. So the time is regular, 30 minutes, 30 minutes, 30 minutes, or it can be 30 minutes and then it becomes 20 minutes, become more frequent. And then the contraction will increase in intensity and duration with walking, meaning that if the woman go and walk, but the contraction is still there, so it will increase more instead. The woman might also feel the lower back pain, and this pain is radiated to the lower portion of the abdomen. So the pain started from the back and then radiated to the lower portion of the abdomen. At the same time, the woman might have a bloody show. What does it mean? Bloody show meaning that the woman might have the vaginal discharge that is mixed between the mucus as well as the blood. So we call this one as a bloody show. Mucus plus blood. At the same time, because of the myometrium activity just now, the os also will have a dilation as well as effaced. So the os becomes more wider and become more thinner. At the same time, yes. At the same time, we also can see the fetus becomes engaged. What does engage mean? Yes, anyone to ask question? Right. So the fetus usually engage. What does engage means? Meaning that the head of the baby already enter to the pelvic brim, already enter to the pelvic inside the pelvic bones lah. So we call it engage. What about the forced labor? So forced labor refers to where the woman might have the contraction, but the contraction is irregular, meaning that 1 hour the woman might have one contraction, full contraction, the uterine contraction, and then after that the contraction disappeared. Then only after 2 hours the woman might have another contraction. So there is no regularity in terms of the contraction time. Normally when the woman walk and then the contraction stop, so this one is the forced labor. And then the woman might have the contraction, but at the upper part of the abdomen, or we call it above the umbilical line. So this one is related to the abdominal pain, but not a really labor pain. And then for the forced labor, when we check for the cervical changes, we cannot identify any dilation and effacement of the cervix. If we check the baby at that time, the fetal head is still can be moved or still movable. So when you try to move the fetal head from the palpation or from the vaginal examination, you can feel the fetal head is still moving. So this one, if you can still move the fetal head, we call it ballotable. Right? So let's move to the next title now. We finish about the physiology of labor. We talk about the dilation. We talk about the effacement. We talk about the myometrium activity. We talk about the causes of labor, involve the progesterone, prostaglandin, as well as the corticotrophin. So now let us see what are the factors affecting labor. So there will be 4 factors that are going to be discussed today. So we call it 4 P's, or some books might say 5 P's. So the first P refers to the power. What is power? Power refers to the uterine contractility and the maternal expulsive effort, meaning that we are talking about the uterine contraction just now. That is the power that we need. But we also need the maternal power, which is pushing during the labor. So if the mother just relax like that, she didn't push out the baby, then the baby will not come out because there is no secondary power or the second power. After this, we're going to see what is primary power, what is secondary power. And then the other factor or the other P in factors affecting labor is passage. Okay, so what is passage? Passage refers to the maternal pelvis as well as the muscles or the soft tissue that support the birth canal. Don't worry, after this we are going to see. And then we also need another P, we call it passenger. Okay, who is the passenger? Of course, we are referring to the baby. So baby is the passenger. The last P is the psyche or the psychology of the mother during labor. What do we mean by psyche? So it refers to the maternal confidence to give birth, as well as the encouragement that the mother might have from the husband, if the husband are allowed or husband is allowed during the labor. So now let's see one by one. I talked about the power just now. I said there is 2 types of power, voluntary and involuntary. Involuntary powers refers to the uterine contraction. It refers to the uterine contraction where the mother might need this during the first stage. Right, so after this, we are going to see what is the first stage, what is the second stage. Don't worry about that. What you want to remember now is that the involuntary power refers to the uterine contraction, or we also call it primary power. The second power that we need is the secondary power. As I mentioned just now, the mother needs to push. to take up the baby or to give birth to the baby. If the mother didn't push out, then we don't have the pressure to push up the baby. So we need this one. So this one we call it voluntary contractions or secondary power. Right. So if we talk about the primary power just now, we want to understand how long or what is the what we call how many times in second that the uterus is contracted. So this one we call it frequency. So normally we measure frequency within 10 minutes. So in 10 minutes, we are going to put our hand on top of the maternal abdomen, and then we are going to measure how many times the contraction occur. So this can be recorded like this. Okay, it can be 2 in 10, it can be 3 in 10, it can be 4 in 10, it can be 5 in 10. Normally, we expect the frequency can be at least 1 in 10 and can go up to 5 in 10. We normally don't want, or we don't want to for the mother to contract more than 5 in 10 because it can lead to the condition that called hyperstimulation of the uterus. So if the uterus is overstimulated, then it can rupture. Uterus can rupture, and this will be a dangerous situation or condition for the mother. So 2 in 10 means that the mother have the contraction 2 times in 10 minutes. 3 in 10 means the mother have 3 contractions in 10 minutes. Same goes to the 4 in 10, which means that the mother have 4 times contraction within 10 minutes. And we also need to measure the intensity. What is intensity? Intensity is the strength of the contraction, whether it is mild, it is moderate, and it is strong. How do we determine the mild, moderate, and strong? It will be based on the duration. What is the duration? Duration is the length of the contraction. Just now, I said that the frequency can be 2 in 10 minutes. But for the 2 times, the length of the duration for each contraction can be 20 seconds, can be 40 seconds, can be 15 seconds. So normally, we will say that the intensity would be mild if the length of contraction less than 20 seconds, right? So if the contraction less than 20 seconds, we call it mild contraction. But if the contraction happens within 20 seconds to 40 seconds, this one we call it moderate contraction. Okay, moderate contraction, 20 to 40 seconds. So if the contraction occurs more than 40 seconds, then we will say this is the strong contraction. So the intensity is strong. The duration is 40 seconds. And then the frequency perhaps can be 4 in 10 minutes. Right. Let's move to the next one. So the secondary power, I already explained to you just now, the ability of the mother to push the baby out. Right. I talked about the first P just now, which is power. Now we move to the second P. Second P refers to the passage. Okay. The passage refers to the hard part of the birth canal and the soft part of the birth canal. What is the hard part? Hard part refers to the pelvic bone of the mother. So there is a variety of the pelvic bones size, but the common one we call it gynecoid. So most of the mother with gynecoid types of pelvis, they have the ability to give birth normally, right? At the same time, we also have the other part of the pelvis. We call it brim, inlet, and outlet. So if you can see from this picture, here is the brim, the most outside one. Okay, this line, the first line we call it. This one is the pelvic brim. So if we see the superior view, this is how it looks like. And then if we go further, that's the pelvic inlet. We call it an inlet of the pelvic. And the last one is the pelvic outlet. So if we can see from the inferior, meaning that if we standing in front of the maternal pelvis now, in front of the maternal pelvis, this is how we can see the inferior view. So this is the first one that we see, the pelvic outlet. And the inside one here is the pelvic brim. Right, I believe that this one is not that important for you. What you have to remember just now, the common pelvic bones, common size of the pelvic, we call it gynecoid, and there are three structures of the pelvic, call it a brim, inlet, and also the outlet. At the same time, we also have the soft part of the uterus. Okay, the soft part have a lower segment of, so the uterus, and we also at the same time the vagina. So below the uterus, we have vagina here, right? So here is the vagina, and then we also have the pelvic floor muscles. So here is the pelvic floor muscles, and then cervical os is here, the opening here, the cervical os that is so important to allow the delivery of the childbirth, right? So here is the passage. Just now I mentioned about the size or the common shape of the pelvic bone. So here is the common one, the gynecoid. Why we say this one is the common one and the most favorable one? Because the diameter is the best, or the diameter is sufficient to allow delivery of the baby. As compared to the other shape like the android, platypeloid, and anthropoid, their diameter is much more smaller, so they don't allow the delivery of the baby through the vagina. Other than that, for the passage, we have the false pelvis and true pelvis. So here above the inlet, we call it false pelvis. The below, we call it true pelvis. Right? It's very forward for that. Now, we finish with the two P's, the powers and the passage. So now we're going to discuss about the passenger. Remember just now I said the passenger is the baby. So this baby, they have a special characteristic, whereas their bones, their skull is not yet united, it's not yet firmly united. Therefore, their skulls or their bones can overlap to each other. At the head, the bones can what we call overlap each other. So this overlap mechanism, we call it molding. Okay, we call it molding. Why do the bones need to overlap each other? Because they are trying to make sure that the diameter of the head is sufficient enough to pass through the birth canal, or to pass through the hard part of the pelvic just now, as well as the soft part that form the birth canal. At the same time, the head of the baby is not rigid. The head of the baby can be rotated. So the baby can rotate, can move the head, and also can flex a little bit down like that. And sometimes it can be extended, meaning to a little bit extend the head. Okay. And the attitude of the baby. Attitude is not a good or bad attitude here, but attitude refers to the head of the baby. Like here, if the baby sitting, or what we call the position of the baby like this, we call it flexion, meaning the head of the baby looking down like that. And then this one, we call it extension. Now, this one is the os just now. If you put two fingers inside the vagina, you can feel the fetal face here. But here, if you can put two fingers inside the vagina, you can feel the fetal head. So this one, we call it flexion. This one, we call it extension. Other than that, the characteristic of the passenger, we call it line. What is line? Line is the relationship of the long axis of the fetus to the long axis of the mother. What does it mean? So, for example, I give you here one scenario. If the head of the baby is here, and then the legs or the buttocks of the baby here, then we will call this one longitudinal line. The other condition, perhaps, when the head is above here, Okay, the head of the mother here, and then the head of the baby also here, and then the buttock is here. We also can call as a longitudinal line. Okay, either head is down or head is here, top here, we call it longitudinal line. How about the transverse line? Transverse line, if the head of the baby is here or if the head of the baby is here, right? So that one we call it transverse line. That's another line, we call it oblique. Oblique if like this, yeah? This one, we call it oblique line, where the fetal head can be here or can be here. That one we call it oblique line. Right, the other characteristic of the placenta is presentation. What is the presentation? A portion of the fetus that enters the pelvic first and covers the internal os. So if the head is here, down here we call it cephalic. Okay, we call it cephalic. If let's say the buttocks is here, we will call it bridge. Or if let's say shoulder is here, shoulder is the first part to enter the pelvic. So we call it shoulder presentation, right? So for the cephalic, it can be vertex. Vertex means if the fetus lie like this. Face, if fetus lie like this. So we call it face presentation. And it can be brow. If the brow is the leading part, we will call it brow presentation. But all of this is the cephalic in the cephalic types. Remember just now I mentioned about the engaged or ballotable. That's one of the signs of true labor. So engagement, or when the fetus baby goes into the pelvic brim, is another characteristic of the placenta. What does it mean? So the engagement is the line of presenting part pass through the pelvic inlet. So that the baby already goes into the pelvic inlet, then we will call it engaged. The baby already engaged. Okay. So now you can see this one is the inlet, and once the BPD refers to the biparietal diameter. So once this diameter goes inside here, then we will call it engaged, baby already engaged. So this one is the ballotable, meaning that the head of the baby is not yet entered the pelvic inlet. Okay. This line is the pelvic inlet. Okay, this line is the pelvic inlet. Yeah. So after they pass through this line, we call it engaged. If they're not passing through this line, the last character of the passenger is station. So the landmark for the station is spine, or we call it ischial spine. So here, I label it here spine. So which means that ischial spine. What is ischial spine? It is a prominent bones inside the pelvis where you can palpate or you can feel it if you do the vaginal examination. You put 2 fingers inside the vagina and you check for the ischial spine. So it is prominent. You can feel this bone. So if let's say the head of the baby is at the same level of the spines or ischial spine, we will record the station as 0. Okay, we will record the station as 0 if it is at the same level with the ischial spine. If the head of the baby above the ischial spine like this, then we will call it like a negative. It can be -1, it can be -2 until -5. What about if the head of the baby already passed through the ischial spine? It's already here. So this one we call it positive. Okay, +1 until +5. Which one we like? Which one is the favorable? So during labor, we want the baby, the station to progress. So it can start with the negative and with contraction during labor, then and then the station will be progress as well. Then it becomes 0, and then it improve again after 1 hour to 2 hours during labor. It will become +2, +3, and finally the baby will be delivered. Right. Okay. Just now I mentioned the last. Here, I think here is the last. The position is the last, I guess. Yeah, the position is the last. So what does the position mean? Okay, the position is where is the location of the head of the baby. Okay, head of the baby. So if you can imagine mother now in dorsal position, A refers to the anterior, so you can assume this one is the symphysis pubis or the pubic bone is here. Here is the buttock. Okay, here is anus, so we call it posterior. So P is posterior, A is anterior. What about right and left? Right is the right, R and L. So R is right and L is left. Okay. So how do you determine the position? You will see this occiput. Okay, or we call it posterior fontanelle. So this triangle shape, we call it posterior fontanelle. So you, through the vaginal examination, you will determine where is the posterior fontanelle. So this one will be the landmark for you. We also call the posterior fontanelle as occiput. So we will label this one as O. O means occiput, or the other name is posterior fontanelle of the fetal head. So this one is the fetal head. So if you get here, if you do the vaginal examination and you found the posterior fontanelle is here, then you will call the position as ROA. Okay, so this one, don't worry, I guess this one is not that important for you. Just nice to know. If you understand, it's good. If you don't understand, okay, because it's two details. Right, and then we also discussed about the fourth P just now. We said psyche, or the psychological of the mother during labor. So in this case, we need the mother to have the people or to have the support by the other person, which is normally their spouse or their husband. So we always allow the husbands to come in. Before the COVID period, of course, we allow the husband to accompany wife during labor, but during COVID, we don't allow husband to go in. I'm talking about the government hospital in Malaysia. I don't know if you have the same policy in Indonesia. And then the mother also might need to be patient during labor, and then they need to be prepared in order to reduce their fears and anxiety during labor. At the same time, they also need to have reduced pain, we have the pain control during labor. So the more that the mother can control their self during labor, then the better that the labor will be, right? So I finished with the first two section of the lecture. Now I'm going to move to the next one, which is the stages of labor. I guess this is the most important part in this lecture. So the stages of labor normally divided into 3, but I added until stage 4. Some books, they included stage 4 of labor, but I want to tell you that the stage 4 of labor is just nice to know. Normally, we talk about 3 stages of labor. So stage 1, stage 2, and stage 3. So stage 1 refers to when, remember just now we talked about the cervical effacement and dilation. So when the cervix is not dilated, we call it 0 centimeter. If the cervix is full dilated, we call it 10 centimeter. So stage 1 of labor refers to 0 to 10 centimeter. Okay, 0 to 10 centimeter. We call it stage 1. Stage 2 refers to the when the 10 centimeter, when the cervix is fully dilated, we call, or complete dilation and effacement until delivery of the baby. Okay, from 10 cm to delivery of the baby refers to the second stage of labor. So now what is third stage of labor? Third stage of labor, from the delivery of the baby, when the baby already delivered, until delivery of the placenta. Okay, delivery of the baby until delivery of the placenta, we call it third stage. So the fourth stage is first hour after the delivery. So let us now have a look at the progress of labor, which is quite different from the first time mother and the second time mother or the third time mother or the first time mother and so on and so forth. So normally the first time mother we will call primi gravida. First time mother we call primi gravida. So for the mother who already experienced 2 to 5 times pregnancy, we will call it multi-gravida because they already have the experience giving birth before. If they already give birth more than 5 times, which is 6 times, 7 times, 8 times, until whatever time, we call it grand multi-gravida. So for the primi gravida, for the first time mother, they took longer for the labor to progress. Okay, so normally we expect the primi gravida will take about 12 hours in the first stage of labor. Okay, so we assume first time mother, they will the os dilation will occur 1 cm in 1 hour. Okay, so 1 hour, 1 centimeter. Therefore, first time mother, they might take 10 hours to 12 hours during the first stage. What is the first stage just now? Os 0 until os 10 centimeter. So for the experienced mother, multigravida, they took less time to progress during the first stage of labor, which is about 4 to 8 hours. So for this mother, we expect the os will open about 1 centimeter, 1.5 centimeter in 1 hour. Just now, primigravida, 1 hour, 1 centimeter. Multigravida, 1 hour, 1.5 centimeter. So they're a little bit progressing faster than the first time mother. How about the second stage? Second stage, I mentioned just now, delivery until the 10 centimeter, from 10 centimeter of fully dilation and effacement of the cervix until delivery of the baby. So for the primary gravida, they normally take about 1 hour for the second stage. And for the multigravida, they take less than 30 minutes. For the third stage, both are the same. Okay, remember just now, third stage, after delivery of the baby until delivery of the placenta. Okay, after delivery of the baby until delivery of the placenta, we call it third stage. So for both primary gravida, for both first time mother and experienced mother, they took about 50 minutes for the placenta to deliver. For the first stage, we divided first stage into 3 phases. Okay, how you want to remember? L-A-T, LAT. L-A-T. So you remember latent phase, active phase, and transition phase. Okay, latent, active, and transition. What is latent phase? Latent phase from 0 to 3 centimeter. Dilation and effacement of the cervix is about 0 to 3 centimeter. You might want to ask me, how do you determine this centimeter? Normally, we will determine this centimeter using 2 fingers. Okay, using 2 fingers. So how do you measure it? You put these 2 fingers inside the mother's vagina. Okay, you put these 2 fingers inside the mother's vagina, and you are going to check the cervix. You are going to go straight away to the cervix and check if the cervix is already effaced or not, and already dilated or not. So the dilation of the cervix that will determine the centimeter just now. Okay, the centimeter. So if you go and do the vagina examination, you check the cervix is about 0 to 3 centimeter. We call this one as a latent phase. If you go and check the cervix and it's already dilated about 4 to 7 centimeter, and this one is the active phase. You might wonder how you determine 4, how you differentiate 3 and 4. It's all about the imaginary. It's all about the perceptions, about our imagination. Okay, imagination. So if like this, if you try to stretch the 2 fingers until you cannot stretch anymore, that one, what we call it, fully dilated. Okay, or fully we call, or completion of the dilation. So active phase, if the dilation is about 4 to 7 centimeter, and transition phase if the cervical os is about 8 to 10 centimeter. That's the first stage. Now, this is the second stage, which is the 10 centimeter from os dilated 10 centimeter until delivery of the baby. So this one is second stage, right? And then this is the expulsion of the baby, right? Where the mother will have to push and the contraction becomes more stronger and become more frequent. Okay. And then how do you know that the mother already prepared to push the baby out? Okay, so how do we measure the second signs, the signs of second stage of labor? The first one, we know that the cervix is completed complete dilation. Okay, completely dilated, or we call it osfully. That's the name that we call osfully, complete dilation and complete effacement, or complete dilation of the cervix is all the same, right? It's all the same. So when the cervix is fully dilated, it is 10 centimeter. Now we already know, okay, this is the signs of second stage. Then we will encourage the mother to push up the baby. So the mother also, they have the urge to bear down or to push the baby out. At the same time, if you go and check the perineum, perineum looks like quite bulging. Bulging, why is bulge? Because the baby now trying to come out, and the head of the baby pushing on the perineum. So that's why perineums become more bulging and then flatten and then move anteriorly. And at the same time, if you check at the vagina, you can see the mixture of the mucus and blood. We call it bloody show just now. So there will be more bloody show coming out from the mother's vagina. And if you check the pressure also, the rectum also, you can see the rectum, we call it anus pouting. So now the head of the baby pushing the rectum as well. Okay, so rectal pressure, that's why you can see the anus of the mother can be open as well. We call it anal pouting. And then the labia begins to part with each contraction. So if you check the labia of the mother, it begins to separate between the right and left, labia majora and labia minora. Now, this one is the third stage, which is the delivery of the placenta. So here is the placenta. So how do you know if the placenta already ready to come out? Okay, so here is the signs. Here is the sign. The first sign is the globular shape of the uterus. How do you know the uterus become globular? This one you can know by palpating the abdomen. You palpate the abdomen and you can feel the globular shape at the fundus. And then the fundus also will rise in the abdomen. You can see the fundus rise more than umbilical line or above the umbilical line. At the same time, you check the perineum, there is sudden gush of blood. Okay, sudden gush of blood, which means that the placenta already separated with the endometrium area. At the same time, you will also see the umbilical cord become more longer, or we call lengthening of the cord. Okay, lengthening of the cord, or you can call protrusion of the umbilical cord. It's all the same, lengthening of the cord or protrusion of the umbilical cord, meaning that the umbilical cord becomes more longer. Right, this one just nice to know. I think we already finished about the third topic today. We talk about the physiology of normal labor. We talk about the factors affecting labor as well as stages of labor. Remember, in physiology of labor, we talk about the prostaglandin, we talk about the corticotrophin, we talk about the progesterone. And then we also talk about the uterine contraction, myometrium activity, cervical effacement, cervical dilation. And factors affecting labor, we talk about the 4 P's, right? We talk about the 4 P's, power, passenger, passage, as well as the psyche or the psychology of the mother. And then we go to the stages of labor. We talk about the stage 1, stage 2, and stage 3. Okay, stage 1 also have latent phase, active phase, and transition phase. How you want to remember? LAT, latent, active, and transition. Now, the last one, we are going to see what are our roles on nursing management during labor. What do we do? Right. So, during the first stage just now, first stage started with the os is 0 until os is 10 centimeter. So, during the first stage, the mother can be at the antenatal ward or can be at the labor room. Okay, so normally when they are in the latent phase, which is 0 to 3 centimeter, they will be at home or they will be at the antenatal ward. Okay, so when they move to the active phase, which is os is 4 to 10 centimeter, they will be transferred to the labor room. Okay, they will transfer to the labor room. So upon admission, whether you are working in the labor room or you are working at the antenatal ward, then you will need to review the medical history, the obstetric history, and the antenatal history. And then you might want to do the vaginal examination. You want to check for the contraction, as well as you check for the fetal status, is that fetal okay? You want to hear for the fetal heart rate, as well as check for the membrane of the placenta. Okay, and then you want to orientate the mother to the environment because you want to make sure that the mother have less anxiety, less fear, so they know the environment. And then you might want to tell the mother about the expected assessments. Perhaps you will tell the mother that after 4 hours, after 4 hourly, the doctor might want to come and check your progress of labor, and then you will explain to the mother in order to reduce their fears and anxiety. Normally in the antenatal ward, we will encourage ambulation. Okay, we will encourage ambulation. The mother can walk around until we send them to the labor room. Then the mother can no longer walk lah, because normally at this time we will ask the mother to lie down on the bed and we'll check for the continuous monitoring of the baby as well as the contraction. So the nurse also need to time the contraction. Remember, we talk about the frequency, we talk about the intensity as well as the duration of the contraction. So the mother might want to check the contraction. So here is the picture how the nurse check the contraction. Normally, I don't encourage because I cannot find any other better picture. But normally, if you can see the palm of this nurse is at the umbilical area, below the umbilical area, right? So normally, I will teach the student to put at the fundal area, above here, above the umbilical line, because that's where fundus is where the place the contraction begins. If you put like below here, you might not feel the what we call the exact time when duration of the contraction started. Okay. And then you will monitor or you will time the contraction within 10 minutes. And in 10 minutes, you will count how many frequency, you will count how many contraction within 10 minutes. Yeah. So this is how it happens. So the contraction of the uterus, it will contract and then it will relax here. So all this one, we call it frequency or duration, 10 seconds duration. And frequency is how many times within 10 minutes. How many times in 10 minutes. Okay. So in this picture, they give 15 minutes because this one for the mother to check. But for the nurse, normally we will check within 10 minutes. Yeah. All right. So other than that, as a nurse, you also need to reduce the maternal anxiety and fears during labor. You provide support, you talk to mother, you listen to them, give emotional support. And then after that, perhaps the mother might need some shaving or minimal shaving if they need episiotomy to be conducted. Normally, episiotomy is conducted for the mother or for the first-time mother. But not all first-time mother will have episiotomy. What is episiotomy? Episiotomy is the small incision that we do at the perineum area in order to help the delivery of the baby, to make the diameter of the birth canal becomes more wider. And at the same time, you encourage the mother to go to the toilet to pee. Why? Because the full bladder will make the labor progress becomes more slower. Okay, becomes more slower because you know the anatomy of the bladder is just under the uterus. Okay, so if the bladder is full, the contraction and retraction of the myometrium cannot take place properly. At the same time, the nurse also need to monitor the urinary output, check the urinary ketones as well as any dehydration. Because normally in the labor room, the mother cannot eat and drink. So that's why we need to check for the dehydration status of the mother. At the same time, we also check for the vital signs. We check for the pulse rate, temperature, blood pressure, as well as respiration. Right. We provide comfort. We teach the mother the breathing technique. Okay, the other technique, relaxation, visualization. And if the mother have no contractions, and you will ask the mother to relax, take a deep breath, and just try to try to relax lah. And then position change. If let's say the mother want to change the position to sit like this, okay, or to lie lateral, for example. So we need to support the mother. At this time, we also provide the analgesics to the mother, or analgesia to the mother. Analgesia to the mother, it can be the inhalation, through inhalation, or it can be through intramuscular. We give IM pethidine, or it can be epidural anesthesia. So this one is a specific one for the mother, where the mother needs to receive it through the IV therapy, continuous, not IV, sorry, the epidural. So you have the continuous medication given through the epidural layer. Right, so this one is the Entonox. The mother use Entonox during labor. So amphetamine normally we give at the buttock. So this one is how the mother looks like inside the labor room. Normally this one is during the first stage of labor, okay, before delivery of the baby. You can see here the cot ready for the baby, and this one the mother. Perhaps this one is quite new picture because the mother wearing the mask, yeah, during COVID time. So here is the machine connected to the maternal abdomen or maternal uterus in order to monitor the uterine activity as well as the fetal activity or fetal heartbeat. Right, so now during first stage also, normally, as I mentioned before, the mother cannot eat and cannot drink because and then we want to protect, we want to prepare for the mother in case we need any what we call operation, like we call cesarean section for the mother. So in case the mother need to go for the cesarean section, then we already prepare the mother. That's why we don't allow eat and drink during labor. But we allow if we can give little bit ice or like a clear liquids at the lip to provide or to prevent the dehydration. At the same time, we also need to record the labor progress using the pathogram. Okay. After this, I'm going to show to you the pathogram. And then encourage the mother to make voluntary expulsive efforts when fully dilation of the cervix is confirmed. So once the mother os is 10 centimeter, we will encourage the mother to push up the baby. So what is pathogram? Pathogram is the graphic display of progress of labor. This will record the cervical dilatation and also routine observation during labor room, inside the labor room, and also uterine action as well as the drug therapy. So all this information we will record in the pathogram. And it also shows the dilation of the cervix through the latent phase to the active phase until the transition phase. So here is the example of the pathogram. So this part is the maternal information. Here is for the fetal well-being, and here is the for the labor progress. Okay, this one if you give any medication to the mother, and this one for the maternal well-being. I believe that you might have different types of form in Indonesia, but in general is the how pathograms looks like. So for the baby, we also need to monitor the baby during the first stage. We also check the what we call the liqua. The liqua, what is liqua? The amniotic fluid inside the uterus. Okay, so it can be if let's say you find out the liqua is supposed to be clear in color. It is not colorful. The liqua, this is clear. But if you can see the color of the liqua is green, it means that the baby already poo inside the uterus. So this one we call it meconium stain liqua. Okay, meconium stain. This relates to the condition we call it fetal hypoxia. Okay, and then we also need to check for the continuous fetal heart rate recording intermittently through a machine we call it cardiotocography machine. I will show to you later about that machine. Don't worry. And here is the interpretation of the fetal heart rate. So during the labor, we also need to check for the fetal heart rate. So the normal fetal heart rate is between 120 to 160 beats per minute. So sometimes the fetal heart rate might go up and then it bring down back. So it is common like that. This is normal. But if you have the intermittent, if you have a continuous like a tachycardia, like a less than 100 and tachycardia means more than 160 beats per minute, that one might indicate the baby might have what we call might have the severe hypoxia. The baby cannot breathing very well, and then might need more oxygen. So here is the fetal heart rate to the uterine contraction. The uterine contraction acts as a stress to the fetus and produce a transient reduction in oxygenated blood supply. So normally you need to monitor the uterine contraction, because when the uterine contraction occurs, the fetal heart rate will go down. But after contraction finish, the fetal heart rate will pick up. So that one is normal. But if let's say during every uterine contraction, the fetal heart rate will go down like that, we call it bradycardia, right? So this in this case, this one can be dangerous situation for the baby. So here is for the first stage. Just now I mentioned about the machine that we determine the uterine activity as well as the fetal activity or fetal heart rate. So we have two transducers here. The first transducer for the uterine activity, the second transducer for the fetal heart rate. Okay, and then the graph will comes out like this. Okay, so this A refers to the fetal heart rate. If you can see A here, and B refers to the uterine activity. So we will monitor the response of the fetal heart rate towards the maternal uterine contraction. Right. So here is the example of the graph. As I mentioned, A and B just now. A here is the fetal heart rate. So fetal heart rate I mentioned just now between 120 until 160. Okay, sometimes it go up, but normally it return back to the normal. See here, sometimes the fetal heart rate can go down below than 120. So it go down below here, but that one is common. But if you can see every time it becomes like this, it's something to check further. So here is the uterine activity. Okay, so you can measure within 10 seconds. Okay, measure within 10 seconds. If you can see from this picture, it's about 1, 2, 3, 4. 4 contractions in 10 minutes. So here is 10 minutes. Okay, right. So here is another example. Here is another example. This one is the abnormal one. Why we call it abnormal? Because every uterine contraction, so this one is the uterine contraction. This one is the uterine contraction. So every uterine contraction, the fetal heart rate will go down. Fetal heart rate will drop. So every time the uterine contracted, now the fetal heart rate drop. We call it early deceleration. This one is abnormal, just to let you know. Don't worry too much about this. This one is late deceleration. See the fetal heart rate go beyond below than 120. The fetal heart rate go below than 120. 120 is here. Now, uterine contraction is here. Uterine contraction. You see every uterine contraction happens. Every time uterine contraction happens, the fetal heart rate becomes 100. This one becomes about 110. And this one becomes 105, something like that. What does it mean? It means that the baby now might have lack of oxygen. So they might be in hypoxic condition. That is a warning signs. In this scenario, we might send the mother to the cesarean section. So these are the nursing diagnoses that for the first time or for the first stage of labor, the mother might have pain, the mother might have anxiety and fear, the mother might have a deficient knowledge and also ineffective coping during the first stage of labor. Now we move to the management during the second stage of labor. So during the second stage of labor, you have to put in your mind, now the mother is ready to push up the baby. Therefore, you need to encourage the mother to push when the contraction comes and to relax when the contraction go. Okay. At the same time, you provide the emotional support, say, okay, good, very good, you are doing very well, give emotional support to the mother, and then provide instruction on how and when to push. So you need to teach the mother how to push and when to push. So normally we will encourage the mother to push with the contraction. And then comfort measures, we provide the clothes at the forehead, we put the cold cloth, and we support the legs when the mother pushing and provide encouragement. Okay, very good, well done, you are doing great. So give support to the mother. And you might also want to give a clear fluid at the lips to prevent dehydration. You also want to check the bladder if the bladder is empty, so that we can support the progress of labor to become more better. At this time, you might also want to think if you need to give the local infiltration of anesthesia. Like say for the mother, remember just now I mentioned about the episiotomy. If you want to do the episiotomy, then you need to give the analgesic, analgesia for the mother, or anesthesia for the mother. All right, and then you prepare the equipment, you have the equipment, you get the privacy, give the privacy to the mother, and then you prepare the equipment, and you have delivery set, you have episiotomy set, you have syringe, local anesthesia if it is required, you have the cleansing lotion, as well as the any oxytocin drugs. Normally, we will prepare what the drugs, we call it intramuscular symptometrin, to be given to the mother after delivery of the baby. Right, so now second stage of the still management of the second stage. We need to prepare that the baby is now coming. We need to prepare the towels, the mucus suction. Okay, this one is the suction, this one is the dry towels, and then we have the cot, okay, the baby's cot, and then you have the radiant warmer. Why we need to have radiant warmer? Because we want to provide the warm environment for the baby in order to prevent hypothermia for the baby. At the same time, you also need to check for the APGAR score. What is APGAR score? Here is the APGAR score. We measure or we assess the baby to what extent the baby can survive extrauterine life. Okay, when the baby, whether or not the baby can survive living outside the uterus. So how do we determine? We check the heart rate, we check the respiratory effort. We check the muscle tone, we check the reflex, color, and also color. So there is five items or characteristics here: heart rate, respiratory effort, muscle tone, reflex, and also color. So normally, if the crying baby, we will give over 100. If the baby cry very loud, and if the baby cry very loud, we can give the heart rate 100. And we can say good effort, good respiratory effort. So now for the APGAR score, we divided into 0, 1, 2. 0, 1, 2. Yeah, 2 is the best one, 0 is the least one. The total score is 10. So you because here we have 5 characteristics, right? So this one, the maximum is 2. Every character, the maximum is 2. So the total mark is 10. And the lower mark is 0. Okay, I think you will learn more in your newborn. Okay, So this one is how after the baby delivered, we put the baby on the maternal chest, shows the baby to the mother, and the mother might feel quite okay, better, and the pain might be resolved if they see the baby because they are so happy with the pain that they already had during the labor. Now the baby already come out to the world. Right, so now the third stage of labor, remember third stage of labor started after delivery of the baby until delivery of the placenta. What do we do at this time? We check the blood pressure, we check pulse, respiration, fundus, check lochia, check the perineum. So normally we check every 50 minutes for 1 hour. And then for the next 2 hours, we check every 30 minutes. Okay. And then you monitor signs of the placenta separation. What is the signs of placenta separation? The signs is like this. The first one, we already see just now, the uterus becomes globular in shape, the fundus will rise, gushing of the blood from the perineum, as well as lengthening of the cord. And then when the placenta is delivered, you will document the time of the placenta delivery. And then after that, you check the placenta. Here is the placenta, and you check the, you estimate the blood loss that the mother have. Normally, the average blood loss between 150 ml or 50 cc until 500 ml. Right? So in the third stage also, you might want to give the oxytocin agent. Just now I mentioned about the symptometrin, or in certain case, you might want to give the IM syntocinon. Normally for the mother who have no medical history, we will give IM symptometrin, but the mother who have heart disease and hypertension, we might give syntocinon. There is a difference in terms of the components of the drug itself. Huh? And then you take the blood, you take the sample of the blood from the cord, and then you check the placenta. And if the mother have episiotomy, you might want to repair it. You might want to suture. So this is how you suture the episiotomy. So this one is the symptometrin. This one is the syntocinon. This is how you take the cord blood. You're going to prick the needle here. And this one is the placenta. You're going to check the placenta, and then you're going to repair the episiotomy if there is any. And then you are going to provide comfort to the mother. You're going to do vulva swabbing if it is required. You might want to give analgesia if it is ordered by the doctor. And then you assist parents to explore their newborn. You might want to give fruits and also food to the mother if it is allowed. Normally in here, we will give the sweet drink for the mother after they give birth, because you know that during labor, the mother lost lots of energy. So we want to give more energy to them, give a sweet drink for the mother. Here is the priority nursing diagnosis for the third stage of labor. The mother might have pain, deficient knowledge, for example, deficient knowledge regarding related to breastfeeding, interrupted family processes, as well as risk for bleeding. So for the baby, you need to check for the apical pulse for the baby. You need to check for the temperature, because newborn baby, they are at risk of getting hypothermia. Yeah, so that's why you need to provide the warm environment for the baby. And you check for the gestational age for the baby, whether the baby is too small or baby is too big. And check for the umbilical cord. Normally the umbilical cord have 2 arteries and 1 veins. And then physical assessment. You will check the if let's say the baby have any congenital abnormalities, right? And then you do suctioning for the baby if it's required. You do nose suction, nose, and followed by the oral suctioning, yeah. And then you provide warm environment. You assist parents to see and hold the baby to provide the early attachment with the parents. Okay. That's all. This one is the recovery time for the mother. Here is how it looks like here in Malaysia. And I guess that's all from me today. Thank you so much. So we have covered 4 topics today. We have talked about the physiology of normal labor. We have talked about the factors affecting labor. We discussed lots of factors for peace just now. We talked about the stages of labor, as well as the management during labor according to the stages of labor, and also cover the mother as well as the baby. I guess that's all. If you have any question you might want to ask. Thank you so much.
All right, thank you very much, Dr. Siti, for the explanation. And then it will be very helpful for the students. Oke, mungkin teman-teman ada yang mau bertanya, silakan bisa dibatasin 3 orang penanya ya.
Mbak Ais kayaknya sudah ada di chat room.
Oh iya Bu, sebentar saya lihat.
Bisa dibacakan dulu.
Okay, Dr. Siti, there is a question from Jasania Fadina. Dr. Siti.
Yeah. I'm looking at the question. Sorry, I'm looking at the question.
Okay.
Yeah.
So
But you can translate it for me. Yeah.
Oh, okay. I'm going to translate it first. Wait. She's been asking about
It's quite long, the question.
labor. Yeah. Wait, I'm going to summarize it first.
Okay. Just summarize for me. Yeah, please.
Okay. She's been asking about dystocia labor or prolonged labor. As nurses, should ask to give the education about childbirth in pregnant women to avoid the occurrence of this dystocia delivery. And then the second question is there any way to prevent the occurrence of dystocia delivery? For example, they recommend exercise. Then the third question is what causes dystocia delivery in pregnant women? And does the large shape of the pelvis can affect the occurrence of dystocia delivery? Okay.
Right.
Or you can answer it one by one.
Okay.
And I will mention it. I will mention it again, the question.
Yes. Okay, thank you for that. So
Okay.
nice of you.
Okay.
Right. Okay, I got the question. You are talking about two different things, yeah? The first one you are asking about the dystocia. The second question you are asking about the prolonged labor.
I'm sorry, Dr. Siti, to interrupt. Rana, could you please turn off your... Okay.
Right, thank you.
Yeah, go ahead.
Okay, so normally the types of the dystocia that happens during labor, we call it shoulder dystocia. So the shoulder dystocia normally related to the big baby, okay, big baby. So this condition normally happens in the mother who have gestational diabetes. Why? Because the mother with gestational diabetes, they have the tendency to have the what we call macrosomic baby, the big baby, yeah. So when the baby is so big, then at that time, when the head already delivered, sometimes the shoulder of the baby stuck inside the pelvic cavity or inside the birth canal, and then we need to do some maneuver. We call it Macrosomic maneuver in order to deliver the shoulder of the baby. So perhaps I can go straight to the second question. You talk about, or the last question. Talk about what are the factors affecting this one. So the first one is condition of the mother as well as the baby size itself. Now, so I can also relate. I'm going to answer the question in one go, I think, because it's interrelated each other. So the causes of this condition, the dystocia, can be big baby, and the other one can be due to the shape of the what we call the pelvis. If the size of the pelvis is less, okay, meaning that the baby's head cannot pass through the birth canal very well. Okay, so we call this condition as CPD, the cephalopelvic disproportion, meaning that the size of the pelvic is not appropriate or is not what we call compatible for the head of the baby. So the baby might be stuck inside that one. So to answer the question whether or not the size of the pelvis can affect the prolonged labor or the shoulder dystocia, just now the answer is yes. Okay, the answer is yes. So always the prolonged labor and the shoulder dystocia, it's also interrelated. Okay, but if let's say for the prolonged labor, meaning that the mother takes a longer time during the first stage and second stage. Okay, the mother takes a longer time during the first stage and second stage of labor. The causes could be related to the position of the head of the baby. Okay, the position of the head of the baby, whereby the baby might need a longer time to come out to the birth canal, because sometimes the head of the baby is not appropriate with the diameter. So remember just now I said the head of the baby is not rigid, it is flexible. The baby can move their head, can rotate, can flex. Yeah. So in this case, the baby might need to manipulate their head. So the baby will take some time to manipulate their head in order to pass through the birth canal. So this one, the position of the baby can also influence the prolonged labor. Yeah, I think I answer it in total. Apakah ada cara untuk dystocia? I think I answer. Misalnya olahraga. Okay, you're talking about if let's say if you are doing exercise more, and then you can prevent dystocia. I don't know whether that one is effective through research. I haven't seen any of them, but I believe just now if I mentioned about the shoulder dystocia, to what extent you can do exercise and then makes your what we call the pelvic becomes more bigger. Okay. So I don't think that one is helpful in case of the big baby or shoulder dystocia. Okay, it might not be helpful for the exercise, but in terms of to strengthen the muscles, to support the pelvic floor muscles, exercise might be helpful. Okay. Right. I think I answered it all. Okay. In one go. I don't know whether you're satisfied with the answer.
I think Justania Fadina is interested
Okay,
with your feedback because they say that. Thank you very much for your answer.
Okay, right.
Okay.
Thank you.
Teman-teman mungkin ada yang mau nanya lagi, boleh? Masih ada 2 pertanyaan. Oke, 2019 ini siapa? Selfie? Mau tanya, silakan.
Ya, jadi saya mau nanya. So I have watched a movie before. There was one of those conversation in the movie like, if a pregnant woman gives birth normally or labor normally, she most likely will defecate. What I would like to ask, is there a way to prevent this from happening? Thank you. Yes.
I'm sorry.
Okay,
I'm sorry.
Selfie mungkin tanyanya bisa
Suara saya jelas tidak, Kak?
jelas, cuman kecepatan. Boleh
Can you
pelan-pelan
little
aja
bit
nggak?
slowly again?
Okay.
Slow again.
Yeah.
So I have watched a movie before. There was one of those conversation in the movie like, if a pregnant woman gives birth like, what I would like to ask, is there a way to prevent this from happening?
Oke. Selfie mau tanya apa sih?
Jadi kan kalau misalnya wanita itu kan dia melakukan persalinan secara normal nih. Seorang ibu hamil melakukan persalinan secara normal. Terus dia tuh kemungkinan akan buang air besar atau mengeluarkan kotoran. Jadi gimana cara mencegahnya, prevent that from happening?
I understand your Indonesia now. I understand. You don't have to translate. I understand.
I don't have to explain it to you, right?
Okay.
Yeah. So you're asking, during delivery, the mother might poo during the delivery of the baby, right? So I always call it twin pregnancy.
It's labor normally.
Yes. I understand. So I call it twin pregnancy. Twin pregnancy means, or twin delivery. One baby come out from vagina, another baby come out from rectum. But the second baby is not the real baby lah. The second baby is a stool lah. Kan? So how to prevent it to happen? Normally, before the labor begins, we will ask the mother, I mean during first stage of labor, I mean before the active phase lah, when the mother about 0 to 3 centimeter, we will ask the mother to go to the toilet if you want to go to the toilet. And in certain case, we might want to give, we call it enema, Ravin enema. So we insert the Ravin, what we call the supplement, or what we call that one, inside the rectum, to make sure that the mother empty the rectum lah. So this will prevent the feces come out during the delivery. But that one is not abnormal. I mean, it's common thing happen. The mother when the mother push the baby out, the feces will come out. Get used with it. Okay.
Selfie, sudah jelas?
Yeah.
Ada yang mau tanya lagi?
Okay, I got it. Okay, I got it. Your answers. Thank you so much. Terima kasih banyak.
Thank you, Selvi, for asking. Thank you.
Okay.
Sorry for my what we call quite hard to understand, but actually I understand your Indonesian language now.
Yeah, it's okay. Teman-teman,
Yeah, I'm sorry. I apologize too.
teman-teman mungkin ada yang mau tanya lagi? Adakah yang mau tanya? Tidak ada. Maybe one last question from me. Okay, so I've been curious. Yeah, I've been curious about something. So I'm on my Instagram account. I follow one of the most famous celebrities in Indonesia. Yeah, and then when she's pregnant, she's running. So she's doing an exercise, and her exercise is running when she's pregnant. So my question is it okay for the pregnant woman to do the exercise, for example, like running? Right. And my second question is the birth, the time for birth is 42 weeks. Is there any cases that women maybe she's pregnant more than 42 weeks, and if there is happen, what causes that affect the woman? That's all. Thank you.
I got your question well. So the first one, you asking about the pregnancy and exercise. There is no limitation in terms of saying that the pregnant woman cannot do exercise. There's no such thing. If you are such an active woman before the pregnancy, you can always continue your exercise, but not to that extreme level. Okay, like when you play in the gym, kan, you raise up 30 kilo at one go. So that one perhaps is too extreme for the pregnant mother. But if you are doing exercise like swimming, jogging, running, whether running in the field or on treadmill, that one you can always continue. Okay, you can always continue if there is any no signs of the worsening condition. What is the worsening condition? For example, if you are running for 10 kilometers every day and suddenly you find out that you're having vaginal bleeding, you're having headache, you're having cramp at the abdomen. So that one is the warning signs, which means that you should stop the exercise for a while, go and see the doctor, right? So, but if you are doing the routine things or the normal things that you already do before you're pregnant, you can always continue, okay? Until, unless it is too extreme. Okay, that's the first answer. The second question, let me recall regarding the, what is it now? I forgot.
The 42 weeks pregnant.
Oh, yes, okay.
Yeah.
Normally, we will say the term pregnancy is at 37 weeks. Okay, 37 weeks, the mother is term. Term meaning that the baby already have the ability to survive outside the uterus if they delivered at that time. Okay, so 37 weeks is term until 40 weeks. So 37 to 40 weeks is term. So after 40 weeks, we call it post-term. Okay. Now the good thing about the pregnancy is that the magic thing I would say the placenta, okay, the placenta will survive or will provide the optimal functions up to 40 weeks of the pregnancy. After 40 weeks of the pregnancy, placenta started to reduce in terms of their functions and their roles. Why it happens, I don't know. I'm not that sure. I cannot explain from the scientific reason. But after 40 weeks, that's what our God created. The function of the placenta becomes reduced. So that's why for the mother with medical illness, we aim to terminate the pregnancy at least at 40 weeks, and we don't allow them to go beyond the 40 weeks. So Aisha asked me why it happens. Why until 42 weeks the mother did not yet give birth to the baby? Is there any mother who experienced pregnancy more than 42 weeks? The answer is yes. The question why it happens? Because I believe there is no, the causes or the physiology of labor is not occurs yet. Remember contraction of the muscles, kan? Contraction of the uterus ataupun contraction of the myometrium, and then we talk about the withdrawal of the progesterone. We talk about the corticotrophin and prostaglandin. So these four things is not happen to the mother. So in certain case, if we need to force the labor to occur, we might give the artificial hormones. Okay. For example, now we understand that they don't have enough prostaglandin to cause the labor. We give artificial prostaglandin to them. The name is PGE, prostaglandin E. So we give the artificial prostaglandin with the aims that we will induce the labor. Okay, we will forcefully or we will induce the labor to start early than it's expected. Okay. Is that okay? Is that answer your question, Aisha?
Yeah, so in conclusion, my first question about the woman who is running and is it right? So, is it a safe exercise for the pregnant woman, right?
Yes, safe and if it is not extreme, it is not beyond your limit, and if there is no warning signs occur.
All right, all right. Yeah, I got the answer. So thank you very much, Dr. Siti, for the answer. All right, so we are in the closing session as the as we experience at the first and the second guest lecture. We will take a picture first. So, Dr. Siti, could you please to stop to share screen?
Yes, yes.
Yeah, so you can see all of it. Alright, teman-teman boleh dinyalakan semuanya kameranya. Guys, please turn on your video. Kita mau foto dulu.
Did I already stop my video, my PowerPoint?
Alright. Okay. Yeah. Okay. Baik. Okay, there are four slides, so we're gonna take a picture 4 times. Okay, teman-teman ya. Oke, baik. Cikal bulan di mana? Cikal bulan. Pakai jilbab dulu. Baik, kita Oke. Sudah. Baik, kita langsung foto aja ya. Oke, Cikal. Ya, baik. Oke, we're gonna start, Dr. Siti. 1, 2, 3. Alright. Wait. Okay. Second slide. 1, 2. Baik. Baik, yang ketiga nggak ada yang mau foto ya? Yang keempat juga. Alright, Dr. Siti. Okay, Dr. Siti, thank you very much for your time to share your knowledge to us. Thank you very much. Let's close the agenda by saying Alhamdulillah together. Alhamdulillah. So, thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Aisha, I would like to apologize if there is any wrongdoings, any difficulties, any shortcomings, yeah? Thank you so much.
Yeah, thank
Bye.
you so much. Bye-bye.
Bye, everyone.
Bye, everyone. Yeah.
Oke. Makasih Mbak Ais.
Ya, sama-sama Bu Ni. Bu Ni baru buka kamera.
Oke.
Terima kasih semuanya.
Terima kasih, Kak.
Terima kasih.
Bu.